Hey everyone, welcome back to another case study. This patient has hand pain and it's really irritable. Can you work out what's going on? Join us in this case study for the assessment, the diagnosis and all the clinical reasoning. So if you're ready to learn, let's dive in. Hey everyone, Khalid here. Welcome back to Clinical Physio. Let's dive into this patient case study. So we have a 78-year-old female who's presenting with pain at the base of her right thumb. And this has been going on for a little while now. It's been going on over the last 6 months, but she does highlight that there's not been any specific trauma that's brought her symptoms on. It just seems to have been gradually worsening over time. So, her key aggravating factors are gardening, cooking, and gripping, all of which are going to need the use of her right hand, use of her thumb, and a lot of activities which will require mobility of the thumb as well, particularly in terms of gardening, using a trowel or using a spade, something like that. And of course with cooking, with lots of chopping, moving around of food, and of course gripping. Things that make her symptoms easier. Painkillers, but unfortunately not much else has been able to help her with these symptoms. And in terms of her past medical history, we know that she has hypertension, high blood pressure, and she has type 2 diabetes. So next we go through her objective examination. Now, when we observe the wrist and hand, we can see that there seems to be a quite clear bony prominence around the first carpometacarpal joint of her first digit, and it seems to present almost as if there's a little bump there. We can also see that it's very painful palpating in this area over the first CMC joint. So we look at her wrist range of movement. We can see that there are mild restrictions to the range of movement in all directions. So flexion, extension, radial deviation, ulnar deviation, supination, pronation to an extent. But clearly there's no pain. These movements might be a little bit stiff because of her general aging, but there's no focal pain. However, we do see that there is pain when we do thumb opposition. Now, this patient can reach to 7 out of 10 on the Kappanji scale, which is a scale of opposition to see how far they can move their thumb. And for this particular patient, we can see that she can reach the first crease, the DIPJ crease of her 5th digit. 6 out of 10 on Kappanji would be right at the tip, 7 at the DIP, 8 at the PIP, 9 at the MCPJ, and 10 on the crease on the most ulnar side of her hand. And she can reach to the DIPJ, which is a 7 out of 10 position on the Kappanji scale. We also complete a CMC grind test for her, which is positive and painful at the base of her thumb. So that's what's going on with this patient. There's 2 things I'd like you to think about. Number 1, what do you think's going on? And number 2, how would you help and treat this patient in your clinic? So pause the video, write down your thoughts, and join us in a second. Okay everyone, time's up. Let's dive first of all into the diagnosis. What did we think was going on with this patient? Well, when patients present with pain around the radial side of the wrist and hand, there are a couple of main pathologies that we could think of. Number 1, we could think about something like a fracture or a post-fracture consequence, such as an AVN of the scaphoid bone. However, this patient has not had a trauma, so there's no reason for us to suspect a fracture or to suspect AVN in the lack of position of a trauma and the fact that she has no major alcohol history, no major steroid history. That would probably reduce those conditions on my list. So then the other 2, which are most common in this region for patients without a trauma, would be a de Quervain's tenosynovitis and one other that is effectively the answer to our case study today. I didn't think this patient had de Quervain's. Number 1, she's in an age group which is less consistent with de Quervain's. We normally see this in the younger population where they're more active with their hand. But secondly is the location of pain, because she wasn't experiencing pain around the radial side of the wrist joint where we know that de Quervain's tenosynovitis presents, but instead more distally at the base of her thumb. The other thing is that the wrist range of movement exercises, such as ulnar deviation, which is going to stretch those key tendons for de Quervain's, wasn't irritable for her. Instead, it was purely the thumb movements, including opposition. And that led us to our main suspicion, the final diagnosis in that group that I was mentioning, which was going on for her, which was osteoarthritis of the first CMCJ, the carpometacarpal joint of the thumb. This is an incredibly common area of osteoarthritis in the body, particularly as we get older and particularly with individuals who are doing repeated movements and really needing their hand. And the fact that her symptoms were all focused in that region, the bony prominence of the different structures around there that we could see on observation and feel on palpation, the fact that she had pain in that region with palpation, and the CMC grind test, which is where we push down on that CMC and move it around, all pretty specific and pretty indicative of first CMC OA. So finally, what do we do for this patient? That was the second question I wanted to ask you, and so hopefully I can give you my key ideas on how we might help a person with first CMC OA. First of all, we would be educating our patient on this condition, particularly with why it occurs and the key ways in which we can try and help them, including heat and ice, particularly for pain relief. This might help us with pacing activities. So for example, if we know that she needs to do some gardening or needs to do some cooking, can she spend some period of time afterwards with some ice or heat to try and relieve her symptoms? And of course, liaising with their doctor to see if we can optimize their pain relief, their analgesia for their symptoms if things get worse. And we mentioned that pacing element, which is really important for osteoarthritis, explaining to patients that if they do lots and lots of activity in one day with their hand, it's more likely to get more irritable. But if they might be able to space their activities out through the week, we get less of that concentrated impact on the thumb. Now, we also know that strengthening exercises are really, really useful for thumb OA, particularly exercises that push the thumb into opposition because we're using those key anterior muscles that will support the thumb. But also another really important exercise is to strengthen the first dorsal interosseous, which runs from the thumb to the index finger. And we can do that by doing resisted movements in this abduction direction of the second digit. Now try this on yourselves. If you put one finger on the radial side of your second digit and push against it, you'll feel that your thumb starts to tighten up. And that's because, as we said, your first dorsal interosseous connects the two. So if you push against the index finger, it will automatically impact the first digit and use those stabilizing muscles that we know has a really positive impact for osteoarthritis. We can also think about lots of advice on modifying activities. We talked about the pacing or using different gadgets which are easier for her to use in general around the kitchen, around the house, perhaps different gardening tools that have a better grip in line with reducing the pressure on her thumb. And then if those don't help, we can start to go further down the line, such as using a thumb spiker, which is a specific wrist splint that protects the thumb more focally, as you can see with the blue thumb spiker on the slide there. And if physiotherapy and the spiker doesn't help, then we can go further down the line where patients can have steroid injections, which can sometimes help, or even surgeries with a surgery like a trapeziectomy, where the trapezium bone is almost removed in order to help with the thumb OA picture, or even we can do joint replacements with surgery now for this area. So lots of options for our patients with first CMC OA.
So everyone, I really hope you enjoyed this video. If you have, please support us by smashing that like button. It's the #1 way that you can help our channel and show us your support. If you want more resources for us, make sure to check out our Instagram account at Clinical Physio. We've got loads of brilliant resources there for physiotherapists. And if you like learning by case studies, be sure to check out our membership platform, member.clinicalphysio.com. On membership, we have the Case Study Club, a brilliant resource where we go through lots of different clinical conditions with MSK experts to show us their clinical reasoning, how they came to the diagnosis with their patient, that will really help you if case studies is the way you like learning. So everyone, thank you so much for watching. My name is Khalid. See you soon here on Clinical Physio.